Dear Chairman, thank you for the kind invitation to present at the European Bifurcation Club 2021 meeting. My name is Maksymillian OPOLSKI, and the title of my presentation is Coronary CT for Guidance of Bifurcation PCI. By the way of background, let me state that coronary CT outplays invasive cuff for display of coronary plaque regarding both its localization and characteristics, and it performs equally well for assessment of median classification, bifurcation angle, and complications of PCI. So maybe we are barking up the wrong tree, and that is the angiogram tree. So what data do we have to justify the uptake of coronary CT for guiding bifurcation PCI? Well, the concept of CT-guided PCI for planning bifurcation intervention was first explored in our center in a prospective randomized clinical trial, which randomized 93 patients with bifurcation lesions to either angiography or CT-guided PCI. Interestingly, the CT-guided approach resulted in lower number of implanted stents, both in the main vessel and the side branch, as well as the higher frequency of non-compliant balloon post-dilatation. Importantly, one of the potential explanations for this observation is that coronary CT, in contrast to the invasive cuff, has the intrinsic ability to show the exact distribution of residual plaque so that you're more prone to cover it with a single longer stent. Number two, coronary CT can be used to predict side branch occlusion in provisional stenting approach, as confirmed by our study group on the largest up to now CT registry, including 363 patients with altogether 400 bifurcation lesions. Indeed, both the quantitative and visually assessed CT-derived result scores, as well as the presence of non-calcified plaque in the side branch, and finally Medina class with any proximal main vessel and side branch involvement, as assessed by cardiac CT, have the ability to predict side branch occlusion after main vessel stenting. And here you can see an example of LAD diagonal branch bifurcation lesion in coronary CT that clearly displays plaque characteristics as well as the bifurcation angle. Importantly, the total CT-derived resolve score was remarkably high, summing up the distribution of plaque at the site of the side branch, the stenosis of both the main vessel and the side branch, as well as the high main vessel to side branch diameter ratio. In addition, we could also see a non-calcified low attenuation plaque at the side branch ostium, resulting in side branch occlusion after main vessel stenting, despite the presence of a safety wire in the diagonal branch. Number three, there is a gargantuan number of studies suggesting a direct relationship between low attenuation plaque, positive remodeling, and spotty calcification, and peri-procedural MI defined by troponin rise or no reflow phenomenon during PCI. Here you can appreciate this ugly-looking low attenuation plaque with positive remodeling and spotty calcium that was actually referred for PCI. However, after stent implantation, the no reflow phenomenon was observed and subsequent troponin rise was reported. Last but not least, coronary CT can be brought directly to the cath lab to assist in resolving proximal cap ambiguity in CTO intervention. Here you can see a complex CTO LAD flash occlusion in a post-CABG patient that couldn't be resolved and solved out by coronary angio despite dual catheter injection. Remarkably, the guide wire kept going to the septal branch or the subintimal space of the intermediate branch, which was actually easily detected with CT co-registration and ultimately put into the right course of LAD, resulting in a good final result. Ultimately, we have the new kit on the block, the so-called CT perfusion, that allows to assess ischemia based on a simple dynamic scan protocol using adenosine or regadenosine. Here you can appreciate complete resolution of ischemia on dynamic CT perfusion after successful recanalization of occluded RCA using antegrade wiring approach without loss of any significant side branch. Now, that's a different story though. Of successful CTO-RCA recanalization, but using the reverse CAR technique, wherein most of the RV branches were lost, corresponding to residual perfusion defect in the mid-inferior wall on follow-up CT perfusion. In conclusion, coronary CT exceeds invasive angio in identification and characterization of coronary plaque in bifurcation lesions. Coronary CT can predict the risk of side branch occlusion and the risk of PCI-related MI in bifurcation lesions. Last but not least, coronary CT co-registration resolves proximal cap ambiguity in osteal bifurcation CTO lesions. Finally, we have the new kit on the block, the so-called CT perfusion, that may aid in estimating the area at risk for side branch occlusion in coronary bifurcation intervention. Thank you.